Good morning and welcome to this YouTube channel, Painfree Partha. And also, the slides are easily, freely downloadable at www.painfreepartha.com. So, today's topic is about anesthesia for patients undergoing hip fracture surgery. See, in this, there are certain facts which are based on evidence, and there are certain few facts which are based on experience also. And in this time, I would like to thank Dr. Bala Venkat for his good and really creative inputs for this, making this slideshow. What is common for both? Both had hip fracture. So there are 77,000 new hip fractures in 1 year. And if you say in our college only 400 cases are in the year are being conducted, so see the volume. And 98% of hip fractures are managed surgically. In a small institute, 500, 600 cases per year, and in a big orthopedic institute, so it's going to thousands per year, and they are managed surgically. Why? Because fixation provides the best pain relief. Unless you fix the hip, there is no pain relief. There is a chance of rehabilitation. They can move. They need not get bed sores. They can move. There is also a mental rehabilitation in this because they are able to move. Reduces the complications of pneumonia, hypostatic pneumonia, and pulmonary embolism. That is why we need to fix hip fractures surgically. It's an age-old problem because you will rarely get patients of 35, 30 who has got no comorbid illness for hip fracture surgeries. They will have, most of the patients will have ASA 3 or sometimes ASA 4. And it is preferable to do the surgery within 36 hours of injury or admission at least. So because they have proved certain things, which I'll again come to later. Pre-operative management. Now 40 years is okay. Every year increase, a possible reduction of 1% of the oxygen organ reserve is a rough game. Now you have 70 years. Now 40, 70 minus 40, 30% of our reduction of our reserves. If you go to liver, probably a 30% reduction of reserves. Kidney, 30% reduction. This is what we expect. It is not that every fellow should have these things. This is a rough game. So age is a problem. What are the three key features of hip surgery anesthesia in the pre-operative period? Number one is pain relief. Number two is resuscitation. Number three is optimization of pre-existing medical condition. So analgesia can be either parenteral, pethidine, IV paracetamol, fascia, iliaca, or PENG blocks, or it can be even epidurals, or sometimes individual nerve blocks like femoral and obturator. So these are all the various modes of analgesia, where now the fascia iliaca block or the PENG block or the individual nerve blocks have become popular, especially fascia iliaca block catheters or a PENG catheters in the preoperative period have become popular. On entry blocks, this is what they call. As soon as the patient comes with hip injury or hip fracture, put the PENG catheter, start a infusion to the catheter. Yes, this is what is the analgesia management pre-operatively in patients with hip fracture. Now we go to indications of iliac fascia. Why I want to tell fascia iliaca block is because it is extensively practiced. It is easy to put. You see here perioperative analgesia for patients fractured neck. See here adjuvant hip surgery. You see here another is above knee. So all these are pointing out to femoral, above knee, and hip. These are all the indications of fascia iliaca compartment block. Now you see here, this is the fascia lata and this is the fascia iliaca. Now you should clearly note that the femoral nerve, this is the femoral nerve, is deeper to fascia iliaca, while femoral artery is superficial to femoral fascia iliaca. So if you drop here the solution of local anesthetics, this may not cross the fascia iliaca and get into the nerve. So you may get failure. Because you are close to femoral artery, that does not mean you are in the nerve. That is very important here. This is psoas muscle. This is iliacus muscle. Now we have to drop here the local anesthetic. See here, this is what is the fascia iliaca compartment block. Obviously, it will trickle down here to go here in this regard. If you give high volumes, and it may block the operators and also probably seep in to cause blockade of lateral femoral cutaneous nerve, which is superficial to fascia iliaca. This is sartorius muscle. So potential space, we already know fascia iliaca, it may go up to vertebral column, inner lip of the iliac crest, all these things. Now we know the anatomy of the fascia iliaca compartment. We are not going to deal extensively in this. Now you see left middle finger. So previously what happened was, I will tell this fascia iliaca compartment block. Previously what happened was, before the ultrasound, what we did was we did go little laterally. Then we go into a first pop vertically. And what I do is slightly slant and go. See, for example, now this is the first pop is like this. Then after the first pop, I angle the needle like this and go to a second pop like this. Because if you go like this as the second pop also, if you give the drug, it is very difficult to hold the needle with such a dexterity. When you inject the drug, automatically it will go to the iliacus muscle, which is just below the fascia iliaca compartment. So that is why we first block, then go like, and the second block. This is what we should do when we are doing this thing. So because if we give large volume very close to the femoral muscles, they were about risking about the so-called intravascular spread. So that is why they did laterally. Now, because of the advent of ultrasound, we know get it medial, get it close to the femoral now. We know the fascia iliaca. We know where is the femoral vessels, all these things. So yes, we can put it here. We can put it here also beneath the fascia iliaca instead of previously we were putting here. Infiltrate cranially, that is what I have told. Even 40 ml of 0.2% BPV can have been used. Press finger down. Okay, now you have injected here. Now injected here. Now you press the thigh here down. So that may be at least decreasing the spread downwards of the drug. Now, if you are given the drug here, now you press the finger like this, tight like this. So the drug will probably go up into the cranial areas. Now we can see this is the femoral nerve, triangular nerve. This is the needle coming, needle tip coming and depositing in the fascia iliaca compartment. This is the iliacus muscle. Move the probe cranially. Yes, we can give the fascia iliaca. Now you see, we have given in some place. And now we are moving the probe there. We can see the drug spread here. Now you can see here, this is the femoral vessels, the femoral artery, and you see now femoral nerve. And this is the fascia iliaca. Now you can see the needle coming here, and yes, every 0.51 ml drug is given, local anesthetic is given, and the femoral nerve is getting soaked superiorly. Now the needle is coming little inferiorly. Now you see the needle coming inferiorly and the drug is injected. So the femoral nerve is beautifully floating here, and laterally, from laterally it is coming. And just again you see another 1 ml, 2 ml, 3 ml slowly given. So this is how a femoral nerve block can be given, or we can put all the here 25 to 30 ml here in this place, so the drug spreads here, spreads here. So here is the obturator nerve. What we are worried about, the anterior branch of the obturator nerve. Posterior branch, hip little less indicated, so it is more towards knee. So anterior branch of the obturator nerve. So this is the peng. Now we can see the anterior superior leg spine and to go down and medially anterior inferior leg spine. Now slightly move medial, you will see the femoral artery here, and this is the iliopectineal line. Now draw straight here in this place. hit the bone and slightly half a millimeter get up, see the needle and see the pen block. And pen block, fascia, iliaca, all these things separately we will take up later. Epidural, yes, static and excellent analgesia will be there. Only thing is about all your other side effects like hypotension, bradycardia need to be there. Like 3-in-1 blocks, psoas compartment blocks were described earlier. All these things have gone. In the femoral nerve itself, we have to give 30 ml and have a distal tourniquet. That is what is called a 3-in-1 block. If you go and drop the femoral nerve 10 ml, that is called femoral nerve block. Same space, if you give 30 ml and a distal tourniquet so that it spreads above, then it is called 3-in-1 block. Which is the best analgesic for hip? Yes, fix the bone. That is the best analgesic for. Now, this is what I have told about analgesia. Now, we are just in pre-op only. Pre-op analgesia. Now we will go to resuscitation. IV access and fluid immediate. Intracapsular fractures bleedless. 10 grams may be the transfusion trigger. Intramedullary nails and hip screws lose more blood than hemiarthroplasties. Keep it around 10 for better walks post-operatively. Yes, 9 level we can operate, get it down without blood. Yes, what they have found out is keep the hemoglobin at around 10 in the post-op so that they walk better, preferable to catheterize. Now, pre-op, intra-op, post-op oxygen requirements has to be assessed. Now, optimization. When it can be postponed, anemia less than 9, what we follow is anemia less than 8. Dehydration on acute uremia. Severe electrolyte imbalance. Potassium is less than 2.8 or more than 6. Sodium is less than 120. Uncontrolled diabetes. Uncontrolled heart failure. Correctable cardiac arrhythmia. Now I will give an example now. The patient has a 72-year-old male and he got a hip fracture. Hemoglobin was 9. We resuscitated. Urea was normal. Everything. We fixed up the case same day. Even though the ejection fraction was 40 or something like that, we fixed up the case the same day. But I will tell another case, a 75-year-old male, where the random blood sugar was 496. Random blood sugar was 496 and the potassium was around 3 and the urea was 74. We did not do anything. We just gave saline, oral, we gave insulin, everything became the next day. The urea was 44, the sugar was 180, we operated the next day. That is what should be the principle. Resuscitate, get the hemoglobin to 10, get the sodium to 130, potassium to 3.5, sugar to 250 less. Uncontrolled heart failure. Completely, the patient cannot lie down like this. All these things, yes, we can postpone by 1 or 2 days. The most important history as far as I am concerned is, was he or she able to walk prior? Okay, she day before yesterday, she fell down and got an injury. Day before yesterday, prior, was she walking? Was she going up? Was she doing the other work? All these things makes almost patients fit immediately. Impacted or unimpacted? An impacted fracture usually does not produce much pain. So patient has, that is the critical thing. We are more worried about analgesia, pink catheter, all these things. Impacted fracture, they will not have any pain. Yes, we can straight away give the anesthesia. Neck cuff fracture or not, because I am going to tell you an important feature here. Neck cuff fracture will come to people who are more fragile, who are more osteoporotic. So that means if the patient has got neck cuff fracture rather than IT fracture, then we are dealing with a more fragile patient, more frail patient. This is what we should understand. Neck cuff fracture is worse patient than IT fracture. If he has got other injuries, is there a decreasing hemoglobin? Because sometimes if you resuscitate, the hemoglobin may come down with IV fluids. What are the comorbid conditions? They have found out the incidence of hyponatremia is 4% and 7-fold increase in hospital mortality. What is the HB value? I have already told. Fluids, the HB original will come. Antiplatelet drugs, aspirin, no problem, go ahead. Clopidogrel, assess patient needs. Proceed with the GA with caution for blood loss. Good surgeons, loss found similar. Definite fixation needs priority. Now we are going for heparin, all these things, wait for something. We are preventing thromboembolism, all these things are okay. But fix, 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 that needs priority. The heart murmur can be postponed. Many have some aortic stenosis, even some fall may be due to it. Yes, yes. It is important to know that this patient has got aortic stenosis. What is the valve orifice? What is the pressure gradient? All these things. That does not mean patient will be postponed. That is what I am very clear. We should know. We should know to target your hemodynamics by knowing the pressure gradient, all these things. We should know the plan of anesthesia by knowing the aortic pressure gradient. Yes, that's all there, but don't postpone. Sometimes fall may be due to a stroke, an impending stroke. For a few seconds, the patient falls, and after that he recovers or she recovers, and then you will find a hip fracture. Patient is fine. That is what we should go into the history very clearly. Timing of surgery is preferably 30-36 hours as early as possible. Optimize and operate. That is what should get the tick. Optimize and wait is not. More than 48 hours. I have been telling again and again, delay to surgery beyond 48 hours is associated with increased 30-day post-operative mortality, complications, etc. This is not a single center study, or this is 275,000 patient meta-analysis. Even pre-op 180 systolic is acceptable. Don't flood with antihypertensives because you give amlodipine and 2 hours you see the BP is still 169 or 172. Again give another losartan. All these things need not be there. You give IV paracetamol, good a pen block. Yes, the pain is relieved and you resuscitate automatically. Your BP will come down by 50 to 60, 30 millimeters at least, 150 millimeters of mercury. That is definitely acceptable. Don't try to treat the systolic pressure aggressively, but continue the drugs if the patient is already on enalapril or whatever it is, amlodipine or something like that. Pre-op mobility, type of fracture neck means IT means better bone, and the patient pain starts after some time. Though the fracture is on 4th of March. Now the 5th of March, even the patient gets pain means impacted has become unimpacted. So you need to put the catheter or block. Now go to anesthetic implications. Now what we have understood from pre-op is don't postpone. Have in a mind to fix the case. So you have to fix within 36 to 48 hours. That is very important. Idealize, optimize, get everything fast, check, check. So, analgesia, resuscitation forms main part. Correct your electrolytes, correct your sugar, all these things. So, L1 to L4 and some S2, S3 is where the nerve roots of hip are important. Opioids are associated with increased post-op confusion. 40% have got mild chronic renal impairment. I have already told 40 years, 1%, 1%, 1%. 45 means 5%. 75 means 35% reduction. So that is to be in the mind. NSAIDs may further reduce the renal function. Yes, paracetamol is effective, and otherwise I will not use much of. Yes, fentanyl IV can be given. Blocks or better. Meta-analysis of spinal and GA, they are told similar results. Scottish intercollegiate guidelines. They should receive some sort of regional anesthesia. This is what is the sign guidelines. Now, position is important. Temperature is important. Yes, that is very important in hip surgeries. You should keep the patient warm. We are in for increased morbidity because sometimes if the patient is hypothermic, there are a lot of problems, especially in old age. Hypothermia adds to it, and they start shivering, and this shivering will increase your oxygen consumption by 400%. You start giving oxygen, you give tramadol. The tramadol is followed by confusion. All these things are basically because of one thing, we have not adequately warmed the patient perioperatively. There's another problem is IV access, oxygen, BP apparatus, catheter, where all these things are. After you are completely done like this, we don't know where is the catheter, how to give IV lines, where is, so that is why we need to keep, micro planning is important. Yes, I'm going to start an IV line, I'm going to put an epidural catheter, I'm going to put a Foley's catheter, all these things. Are they accessible or not? That is what is micro planning. Yes, we need to be very clear. Yes, this is where is the thing, so that we can be accessing these things in the intraoperative period. Intrathecal opioids, no to morphine, yes, fentanyl is okay, PON is there. An anesthetic experience, one anesthetist, what he does is takes a 10 ml syringe and 4 ml of levopipivacaine 0.5%, fentanyl 100 max, makes into 10 ml and give 2 to 3 ml. And he uses femoral block also. And before positioning, hypotension is rare, he said, but the surgeon should be very good. He should be completing the work. That is what is important in this technique. This is not given in evidence-based medicine, but in institute practice. Orthopedician is a better OTSN for holding positions. Many times, if an orthopedician puts a spinal like this, he knows where to hold. He knows the surgery or hip fracture. He will hold our spinal position in such a way that there is no pain. We don't need to give any narcotic fentanyl at all. No worry about cognitive dysfunction. He does the work very well. Type of anesthesia, there is so much. All types are described for. So any meta-analysis is almost impossible. CSCA, low dose spinal, is very important. You just give 0.6 for ADS. It is enough to do hip. 1 for 90, 1 to 1.4 for 80, 1.6 to 180. A top up with epidural infusions, probably with low doses, minimal hemodynamic changes. Just put a CSCA and give only 0.5, 0.6 ml of bupivacaine intrathecal for hip surgeries. Yes, we can top up after 1 hour if the surgery proceeds. This technique, start an infusion post-op, 6 ml or 7 ml of 0.15% bupivacaine or 0.1% bupivacaine. Yes, we are in for a patient that does not have any hemodynamic imbalance. We can throw our ephedrine out, or we can just keep the mephedrine out of the trolley. This technique is evolving slowly, low dose spinal with continuous epidurals. There are people who give low dose spinal along with PENG blocks, along with PENG blocks, along with femoral and obturator blocks, along with fascia iliaca compartment blocks. That too works very well. People give 1 ml of bupivacaine with 25 mg of fentanyl intrathecally, followed by or prior to that, you just give the blocks. Many of the patients are well done with this type without much of hemodynamic disturbance. Mortality is very high, 12%, 125%, 85 years, two more comorbid conditions. Cognition is query. Previous, all these things put towards mortality. If he has got two comorbid conditions, for example, Parkinson and wheezing, for example, diabetes and hypertension, for example, stroke with ischemic heart disease, two comorbid conditions, we are in for a high mortality. Cardiac failure and myocardial infarction in 2 days, pulmonary embolism second week, and bronchopneumonia. Yes, I have seen one patient the first day itself or the fifth day. Patient was about to be discharged. He said, tomorrow I will go because tomorrow is an auspicious day. And as soon as the surgeon enters his room for him to get discharged, he stands up to thank the surgeon, drops dead immediately. We thought that is because of the pulmonary embolism. Yes, that is possible in the second week. Bronchopneumonia is a common cause of majority of late deaths, around 2 months, 3 months. Maintain MAP. That is very important. If the age is 100, MAP is 100. Age is 90, MAP is 90. This is a very simple formula. You have to maintain MAP. Don't get your 180 BP giving amlodipine lot, get it to 120, and as soon as you give us the spinal, get the systolic to 70. This is what is not to be done. So maintain the MAP at 90 years, 90, 80 years, 80, 100 years, 100. This is what we should approach the patient for hip surgery when they are coming with extremes of old age. Bone cement implantation syndrome is a special separate topic, but this is characterized by hypoxia, hypotension, and unconsciousness. This is what is important. At the time of cementation, prosthesis, reduction of joint, limb tourniquet inflation. So when they cement and drill like that, yes, it is possible hypoxia, hypotension. Hand on pulse on the monitor should be there when they apply the cement. That is very important as a basic funda of monitoring in hip surgeries. Grade 1 BCIS is moderate hypoxia. Grade 2 is severe hypoxia. Grade 3 is you need CPR. This is what is a BCIS. There is not much of treatment. Aggressive oxygen, fluid resuscitation, vasopressors, and ventilation. The patient is severe CPR, put the tube and start whatever inotropes you know of. Post-op pain, different types of surgical fixation of different analgesic requirements. Hemiarthroplasty may be different from total hip. Hemiarthroplasty may be different from dynamic hip screws. Nowadays, newer hip screws have come. Tuck put it becomes one becomes two like this, something like a snake. So all these things are less painful. If you put this thing like this and start or a big incision, DHS, all these things matters when you have post-op pain. So this is a transverse process. So was muscle bowel. So PNS is better than USG for plexus block. A new approach to analgesia is extended release epidural morphine. This is Depaform. Even in RA, greater consideration to be given cardiac output monitoring, Doppler, etc. So major cases plus cardiac disease. This is what is important, especially revision arthroplasties. Already AHR is a partial hip is done. They are going to remove that and put THR. This is revision. Anytime virgin surgery is easier, they bleed less. If they do revision, they may be bleeding. A lot of hemodynamic disturbance is there. When you have this case, along with a patient with ischemic heart disease, where your so-called ejection fraction is 35 to 40, then yes, your invasive monitoring lines ready for inotropes, all these things should be there. Now what? As a just analgesia, resuscitation, comorbid illness. The mindset should be fixed earlier. Hemoglobin values 10 is better for better walks. Get the urea creatinine down by resuscitations. Blood ready, especially in revision surgeries. Thromboprophylaxis is heparin or mobilize earlier. Assess the cardiac status and other injuries. Pre-op and intra-op positioning. Be ready for your micro planning. Very important. Sometimes you give the drug and you cannot reach the IV axis. Pre-op and intra-op positioning, reaming and bone cement implantation. Temperature maintenance, very important. Low dose spinal followed by a post-op epidural infusion. A 75-year-old male with hip fracture with 8 grams, RBS of 130, echo normal. Now what I should do here? Early fascia iliaca block. Check BP and drugs to continue because he's having already some drugs. Pre-op, intra-op blood. Probably I will load a central line, catheterize and monitor the urine output. Need not do pre-medication. Already I have given a fascia iliaca block. Oxygen SOS. I will give a spinal pipifentanyl 1.6 or 1.8 ml with fentanyl 25 mics and paracetamol. Monitor blood chemistry like urea, creatinine, and electrolytes.